All right, well, thanks for the invitation, and I'm going to discuss then these two topics that are passions of mine, and there's a lot to get through, so we'll jump right in. The first is on cardiac amyloidosis. So I'll start with a case presentation. This is a 70-year-old Caucasian man who had an elevated screening PSA, ultimately led to a diagnosis of prostate cancer. He underwent a radical prostatectomy, which went fine, but afterwards he had problems with lower extremity and scrotal edema. He had the echo that I'll play here, and you can see he has moderate LVH with normal systolic function, but he had significant diastolic dysfunction and elevated RVSP. His EKG is in the lower right, and you can see that the voltages, while strictly speaking are normal, they're low for the degree of LVH that he has, and he also has an inferior infarct pattern. His astute outpatient cardiologist was suspicious about a diagnosis of cardiac amyloidosis and sent off laboratory studies, which we'll talk about in a little bit, but confirmed that he had elevated free lambda light chains. This led to a referral to a hematologist who did a bone marrow biopsy, which confirmed a lambda light chain restricted plasma cell population and amyloid deposits present in the blood vessels, and he was referred to our center for a question of his best chemotherapy options. I'll come back to this case at the end. So with amyloidosis, I think it's always good to start at the basics. What is it? The term comes from the Latin word amylum, which means starch, because the deposits were felt by early pathologists to look starch-like, even though they are not. It's a generic term for many diseases. What they have in common is that there is a protein that is misfolding, stacking onto one another to form these 8 to 10 nanometer fibrils that you can see on the lower right in the electron microscopy images, and it deposits extracellularly. What determines the type of amyloid you have is what is the protein that's depositing. And there are dozens of different types, but fortunately you don't need to know about dozens of different types. There's only a couple that you need to know about, which are the systemic forms that can involve the heart. And a quick word on the nomenclature is that you always use the letter A to start for amyloid, and then the second letter or letters refers to what the protein is that's depositing. So L for light chain or TTR for transthyretin. I'd discourage the terms primary, secondary, senile, etc. So to understand AL amyloid, we need to take, I promise, a brief dive into hematology. So to remind everybody, plasma cells reside mainly in the bone marrow and make antibodies, and antibodies are made up of light chains and heavy chains. And the light chains come in two overall flavors of kappa and lambda, and they determine part of the antibody specificity. So now imagine you have a plasma cell population that essentially becomes malignant. You have a clonal expansion of it, and three things will happen. First off, the plasma cells will take over some percentage of the bone marrow, which may be a little or maybe a lot, but some percentage. Number two is that the plasma cells will produce a clonal antibody, whatever the plasma cell was destined to produce from the beginning, in this case IgG lambda. And third, they will typically produce an excess of whatever light chain goes along with that antibody. So again, in this case, lambda light chain. At that point, there are three possible outcomes. The cells could take over a small percentage of the marrow and not cause any problems. The antibody and light chain that are being made can come out harmlessly in the urine, and this is what's called monoclonal gammopathy of undetermined significance, or MGUS. It's quite common, particularly in older individuals, and nothing needs to be done for it other than monitoring. The second outcome is that the plasma cells themselves can be more malignant. They can spread more in the bone marrow, and they can start causing problems like anemias and fractures, and that, of course, is myeloma. The third possibility is that regardless of how much of the marrow is taken over, the circulating light chains happen to be ones that are prone to misfold and deposit, and it is that we call AL amyloidosis. So you can have amyloidosis with or without myeloma. That just depends on how aggressive the cancer's cells are themselves. But again, they don't have to go together, but they are all from the same essential process, which is a malignant plasma cell. So we'll come back to AL amyloid in a little bit, but I want to say a few words about the other main type, which is transthyretin. So transthyretin, the name comes from its function. It transports thyroxine and retinol, and it is prealbumin. It's the same thing, it just goes by two different names. So it's a normal protein that we all have that's fairly abundant. It almost completely circulates as a tetramer, meaning 4 subunits together, as you see in the ribbon diagram in the upper right. And importantly, there's a small amount that's in a monomeric form and steady state at any given time, and it's the monomers that are inherently amyloid amyloidogenic, meaning they are inherently prone to misfold and deposits. So if all of us lived long enough, we would probably all develop amyloid deposits with transthyretin. Now, in addition, people can be born with mutations in the transthyretin protein that favor the monomeric form and make it more amyloidogenic. So the wild type form of the disease, this is without the mutations, this is what's sometimes called senile form of the disease, is the normal protein. For reasons that are unclear, it strikes men much more than women and almost exclusively deposits in the heart. And in fact, it was so common that pathologists used to refer to this as benign deposits in the hearts of the elderly because they would see this so commonly. They're not so benign, we now know. This is a nice study out of Mayo Clinic from a few years ago where pathologists took 109 patients who had died of diastolic heart failure, but where there had been no clinical suspicion for amyloidosis, and they compared them with age-matched control patients, and then they had pathologists blindly review the slides to see if they saw significant amyloid deposits. So a couple things are interesting from this. One, if you focus on the black bars, is that as you get into the 80s and 90s, patients who died of diastolic heart failure were quite likely to have actually had lots of amyloid deposits in their heart as the probable cause of their disease, even though in none of these cases had it been had there been suspicion by the treating cardiologist. Number two is that if you look at the control patients, about 15% of them in their 80s or 90s actually had significant amyloid deposits in their heart. So you can see that as people get older, this gets more and more common. Now, if we switch to the familial form of the disease, this is people who are born with mutations. And the mutations tend to cause deposits in the heart, the peripheral nerves, or both. And there's many different mutations that have been described. The only two I'm going to mention, one is called the V30M mutation, and this is common in several parts of the world, including Europe and Japan. Portugal turns out to be the epicenter, and it causes mainly a polyneuropathy form of the disease. But the mutation that we see by far most commonly in this country is the V122I mutation, and the mutation is actually present in probably about 3 to 3.5% of individuals of African descent. So when you think about the demographics of the United States, that's a lot of people. That's by far the most common mutation we encounter, and this causes a mainly cardiomyopathic form of the disease. So how common is it? How important is this mutation? So this was a very nice study that was published in the New England Journal a couple of years ago, where they looked at a longitudinal atherosclerosis study called ARIC. So even though it wasn't an amyloid study, the nice thing is they had blood on all the patients, they could go back and genotype all the patients, and they had longitudinal data in terms of what happened to them. And they went and genotyped everybody who had been in the study for the TTR gene, and they found several interesting findings. First off, the prevalence of the mutation was 3.2% in self-identified individuals of African descent, whereas it was virtually not seen in the other population, 2 out of 10,000 some odd people. Those who had the mutation had more systolic and diastolic dysfunction, higher NT-proBNP, and 7% of these individuals on echo had overt signs of amyloid infiltration. So that gives us at least a floor of what the penetrance is of the mutation. So it's certainly not that everybody with the mutation develops the disease. 7% is undoubtedly overall an underestimate, but it gives you a sense how actually reasonably common this is when you again consider the population of the United States. So how does this disease present? I like to say the only way to diagnose amyloidosis is to consider the diagnosis, meaning that it is not one of these diagnoses that will come out and smack you. You have to actually be thinking about it and then do the appropriate testing. And for AL amyloidosis, the key is that it usually involves multiple organs. In a given patient, it doesn't typically involve all of these organs, but it's rare to have it only really involving one. So we'll talk more about the heart in a moment, but in terms of the other common sites of involvement, the kidneys are common and will mainly be manifested by proteinuria. Neurologic involvement is common, causing either peripheral or autonomic dysfunction. Dysphagia is common from esophageal involvement, constipation from colonic involvement, alkaline phosphatase elevation from liver involvement. And then big tongue, macroglossia, you can see a picture in the middle there of a patient with that. Carpal tunnel syndrome because of deposition in the carpal tunnel areas itself. So again, if you see a patient with rapidly progressive heart failure who, oh, by the way, just developed bilateral carpal tunnel syndrome, this is probably what they have, or a patient with new heart failure who has nephrotic range proteinuria that's otherwise unexplained. This is likely what they have. In terms of the cardiac manifestations, it's of course a disease of more diastolic than systolic dysfunction, although they can develop both. Heart block is very common, particularly with transthyretin disease. Tachyarrhythmias are common, and low voltages on the EKGs are frequently seen, but I would emphasize that you'll miss a lot of cases if you're counting on this. So plenty of patients don't have low voltages, although if you see it, it should be suggestive. And patients often will have a chronically low-level elevated troponin, so not levels of 5, 10, 20, but of 0.3, 0.5, 0.8, et cetera, because of ongoing chronic destruction of the cardiomyocytes. In terms of imaging, the main thing you're looking for is increased thickness of the heart, particularly in the ventricles, although you can see it in the interatrial septum, you can sometimes see it on the valves. These are just all amyloid deposits. If you do see the combination of increased ventricular mass and low voltages, it is very specific for amyloid. Here is a typical EKG in an amyloid patient. You'll notice the low voltages in the limb leads. You will see a first-degree AV block, and you will see Q waves inferiorly and anteriorly, the so-called pseudo-infarct pattern that is often seen in the disease. So here are two echoes, and I ask which of these two patients has amyloidosis, and hopefully everybody would pick up on the one on the right, but of course this is a trick question because the answer here is that they both did. And the point is that there'd be no way in the world you could look at the echo on the left and say that's a patient with cardiac amyloidosis. So how do we know that she did? Well, because she also presented with carpal tunnel syndrome and neuropathy and ultimately got the diagnosis. So again, if you're waiting for that echo on the right, great that you'll pick that up, but you're going to miss a lot of others. So you have to have the clinical suspicion that for the reasons I was mentioning before. And once you are suspicious, how to diagnose? And really the answer with this is biopsy. You cannot rule it out or in with a laboratory assessment. And the nice thing about this disease is that it's one of the few diseases, really one of the only from the heart standpoint, that a biopsy just will not miss it. That if you biopsy the clinically involved organ, it is essentially 100% sensitive and specific. And remember when you're doing a biopsy that it's not just to make the diagnosis of amyloidosis, but to subtype it as well. Is it AL, is it transthyretin, or is it one of the more uncommon ones? Whatever you do, please do not order fat pad biopsies, and definitely if you do order a fat pad biopsy, don't let it talk you out of the disease if it's negative. You'll see quotes of 70% sensitivity. That's much higher than reality. That was from old data with patients with only overt disease. And often, even when it's positive, it can't subtype it because there's not enough amyloid there. So as this is not a diagnosis you want to get wrong, in general, if you're suspicious, you should biopsy the clinically involved organ, which given the audience here, generally is going to mean an endomyocardial biopsy. In terms of treating AL amyloidosis, there's really parallel paths. You have to treat the consequences of the organ dysfunction, like the volume and the arrhythmias, and then to treat the clonal plasma cell disorder. From the cardiac-specific treatment, the mainstay is volume control. So often because patients are relatively hypotensive, they're left drowning in fluid. Can't do this, of course. So they have to be properly diuresed, and salt restriction is absolutely key. Generally want to avoid some of the other standard heart failure therapies like digoxin, beta blockers, ACE inhibitors, ARBs. Why? Because there's a lot of hypotension that the patients will have because of autonomic dysfunction, the fact that they typically have a small stroke volume with a small cavity, heart block. So these are generally not advised. Digoxin can also bind to amyloid fibrils and cause dig toxicity. Midodrine, in fact, is often needed as a peripheral vasoconstrictor for postural hypotension. And then treatment of atrial arrhythmias is often needed, as atrial fibrillation is often poorly tolerated with this disease. How about ventricular arrhythmias? The old paradigm was to say don't place defibrillators in these patients. I think that is outdated. It came from a time when the disease really had poor treatment options, and if you got diagnosed with AL amyloidosis, it was essentially a death sentence, and why would you want to put in a defibrillator and have the person be shocked as they're approaching death? But the prognosis with this disease has gotten much, much better because of the chemotherapy options getting so much better that I'll mention in a moment. And so now it starts being something that maybe it makes sense. So we did a study here where we did outpatient telemetry monitoring, saw that 75% of these patients on brief outpatient telemetry monitoring were having episodes of non-sustained VT, offered defibrillators inhibitors, which most of them took, and in less than a year of follow-up, 6 of the patients had episodes that likely would have caused sudden death, that 5 were successfully resuscitated. This was a study that we did from a few years ago, and certainly the clinical experience since then has matched this. In terms of chemotherapy options, I don't want to go down the rabbit hole too far with this, given that this is a cardiology audience, but it's worth mentioning a couple of things to emphasize how much better this has gotten. So this was the original trial that showed that chemotherapy worked. So this was in the New England Journal in the late 1990s, and it showed that colchicine, think of that as the placebo, it didn't do anything, was much worse than chemotherapy, in this case melphalan and prednisone, although you can see that overall outcomes here were still pretty dismal. There was a long time where the thought was, gee, if you have this disease, you got to try to get them to stem cell transplants, and it was based on a bunch of observational data. And there was a single randomized study that looked at this. It was done in France of 100 patients who were randomized to the state-of-the-art chemotherapy at the time, which was melphalan and dexamethasone, versus stem cell transplants. And to everyone's surprise, the group that actually did better was the group on the standard chemotherapy, not the stem cell transplant. And when you consider that compared to the 2000s, stem cell transplant has changed very little for this disease since then, whereas the chemotherapy has changed markedly. Nobody would ever get melphalan and dexamethasone today. You would expect that if this trial was repeated, you'd see these curves separate anymore. So the big picture is that stem cell transplant has a very limited role, in my opinion, in this disease, if a role at all. But rather, there's a whole host of newer chemotherapy agents, which were all developed for myeloma, which have really transformed the ability to take care of patients with this disease, such that the large majority of the time, patients with this disease, you can control their light chains. You can get either perfect control or near perfect control. And if the first thing you try doesn't work, there's many, many other options since then. So, for example, this agent daratumumab, which was approved in the last year or two for myeloma, has been incredibly successful, even for patients who had been resistant to other therapy options. So the main point is that now with this disease, prognosis has gotten much better because the chemotherapy options have gotten so much better. I'll just say a few words about transthyretin amyloid, because there's a lot of excitement about treatment options here. So the traditional view was that if you had the wild type form of the disease, you just had to give supportive treatment. There really wasn't anything else you could do. If you had one of those mutations, the familial form of the disease, you could actually think about a liver transplant, because transthyretin is made by the liver, and so if you had if you have an inherited gene where the liver is producing mutated transthyretin, if you replace the liver, then it will halt progression of the disease. And there's actually something to this. There's obvious downsides, namely you need a liver transplant and limited availability, and really is only appropriate for the polyneuropathy form of the disease. So more is needed, and there's a lot of interest in terms of various drug therapy for this disease with 2 approaches. One, remember I was saying that it circulates as a tetramer, but it's the monomers that deposit, is what if you could stabilize the tetrameric form and not let them form into monomers? So there's several drugs which have been aimed to that. The other approach is to just knock down production of transthyretin altogether at the RNA level, and so a couple of companies have been pursuing that. This is the agent that's sort of farthest along. This is called Tafamidis. This is one of those stabilizer of the tetramer approach. And they did this trial in patients with polyneuropathy. And unfortunately, there were significant errors that were made in the clinical trial design. And what ended up happening, if you look at on the left, the intention to treat population, is that there seemed to be a benefit, but you'll note that the p-value was 0.068. It just missed statistical significance. So now imagine you're a regulatory body. Do you approve it for this disease where we don't have a therapy? It seems to work, it was safe, but it didn't quite hit statistical significance. And so the European Medicines Agency said yes, and the similar agency in Japan said yes, and of course the FDA said no. So that's, for better or for worse, that's where it stands, and you cannot prescribe this in the US. However, the makers of this drug launched a trial in a population that's much more relevant to us in the US, which is those with the cardiac form of the disease, both wild type and familial, and that trial completed enrollment over a year ago and is going to actually finish the last patient will finish the trial at the end of this calendar year. So by about this time next year, hopefully we will have results of this trial, and if positive, we'll have an agent to use. Just briefly want to mention this agent, diflunisal. This is an approved non-steroidal anti-inflammatory drug. You could prescribe this for arthritis pain for pennies, and it turns out that non-steroidal anti-inflammatory drugs, some of them, particularly diflunisal, also stabilize that tetrameric form. So for the polyneuropathy form of the disease, there was this study of diflunisal versus placebo, and as you can see, significant, both clinically and statistically significant advantages with diflunisal. So for patients with a polyneuropathy form of the disease, it's actually probably a pretty good option. Unfortunately, being an NSAID, it's not a great option for patients with cardiomyopathy because of obviously the fluid retention and kidney dysfunction that these patients are prone to. And I'll just mention that there are two companies who have pursued approaches at knocking it down at the RNA level. The one that's furthest along was a company that had a little bit of bad luck. They named themselves after a constellation in the sky that was called Isis. And then a couple years later, events overtook them. And they ended up a couple years ago changing their name to Ionis. But that's a true story. Anyway, they had one agent in trial for the polyneuropathy form of the disease. Another company called Alnylam had one for both the polyneuropathy and cardiomyopathy form of the disease. The long and short of it, just a couple weeks ago for Ionis's agent, they announced that it met its primary endpoints with a very impressive p-value, but there are some safety concerns around thrombocytopenia, so we'll see if it gets approved or not. And right now, neither of these agents is in an active cardiac study. I'll just close with saying a couple of words about heart transplants for this condition. So it used to be thought to be crazy that when they were done, the results were terrible. In general, these were done with patients with AL amyloidosis. They would put a new heart in, and you would get amyloid infiltration in the new heart, and or the patients would have so much other organ involvement that they would die from multi-organ failure. But what if you selected patients very carefully who didn't have a lot of other organ involvement? For the AL patients, you treated them with effective chemotherapy. Could you do it? And so a couple of centers, starting with Mayo Clinic and then a couple others, including our own, started doing this. And so we published our early experience a couple of years ago. This was from the first 5 years that we were really doing it. And over that time period, there were 19 patients. We've transplanted 6 more since then. And it turns out that if you're very careful about how you select them and make sure for the AL patients the light chain control is good, they can do very well. So as you can see, we've had a 92% survival of those patients. It's actually better, frankly, than our overall transplant survival. With only one patient who's had recurrent amyloid in the new graft, and the 2 deaths were infectious deaths early on that had nothing to do with their amyloid. So it does, I would say, have an option if you choose people carefully. We interrogated the UNOS database and looked nationwide about patients being transplanted for amyloid, and we looked sort of pre-2007 and post, using 2007 as the cutoff because that's when the new chemotherapy agents came on board. And compared to patients with restrictive cardiomyopathies, you could see the outcomes were much worse in era 1 and were basically equivalent in era 2. And MGH published, which is one of the other centers that will do transplants for this, published this data, which was nice. Hate to see it, but good data, which was that if you are an AL amyloid patient and you're on the wait list for heart transplants, if you don't get a transplant, you will die very quickly. Versus if you're on the transplant list for other reasons, where in fact 50% of them are alive 4 years and on. So if a patient has AL amyloid and needs a transplant, you've got to do it quickly. So back to the case. To remind you, this was a 70-year-old man who had a suspicious echo, monoclonal lambda light chain, and had a bone marrow biopsy consistent with amyloidosis, and with the question of what chemotherapy to use. But remember that he had a diagnosis of amyloidosis, but not of AL amyloidosis. All we knew was that he had light chains. And I mentioned earlier, MGUS is actually quite common as patients get older. So we sent the samples for further analysis, and it turned out that his amyloidosis was transthyretin. So the type of chemotherapy to use was none. He didn't need chemotherapy. He had MGUS, and his actual amyloidosis was transthyretin. So he ended up being treated symptomatically. Of course, he enrolled in that clinical trial that I mentioned and has not needed any chemotherapy for his MGUS, and he's doing well 4 years since the diagnosis. So the take-home points I'd like to leave you with are, number one, to think about amyloidosis. It's not common like hypertension and coronary artery disease are common, but it's not that rare. And there's a clear phenomenon. After you've diagnosed your first amyloid patient, you'll start diagnosing a lot more because you think about it and know what to look for. Determining the subtype is key. AL amyloidosis treatments have gotten much better. This is not a death sentence anymore. There's much better chemotherapy options. And for transthyretin, there are emerging therapies that are likely on the way. I think there is a clear role for the right patients with defibrillators and heart transplants. And a multidisciplinary approach with centers of excellence and clinical trials are really important. We established our center almost 10 years ago, and now are the second biggest in the country. We see over 100 new patients per year with amyloidosis. If you have any questions or have a patient you want to refer, a simple email of amyloid@stanford.edu. And these are the many members of our Amyloid Center team. So thank you on that. I don't know if I should take any questions now or...
Yeah, let's do a couple of questions.
Couple questions. All right, thank you.